ultimately. So yeah, I'm gonna, I will say this talk in some ways takes me a little out of my comfort zone, but it's been a really gratifying part of the sort of silver lining of the pandemic for me, which is that as a statistician, I tend to focus mostly on sort of the statistical methods aspects and causal inference and things like that. But really, I think as for many of us, the pandemic has brought out sort of new impetus for research and new opportunities. So here I'll be describing some work that a team of us at Hopkins started in March, really to think carefully about measuring population level mental health during the pandemic. As a sort of aside, it's a little ironic because actually this whole body of work started because of people chatting, after like at a going away party for someone. And, this sort of interaction that can't really happen right now, but, sort of one of those, it was like March 8th or something. And, we sort of could feel this was coming, but it hadn't really quite hit the US, at least the East Coast. And so at a going away party, people, started talking, my primary appointment's at Department of Mental Health. So we all were thinking this is going to be potentially really important for mental health. And like we needed to make sure to get sort of mental health topics on the radar screen and get people thinking about it. And that has then again sort of grown into this group, mostly volunteer, to try to again sort of measure and document population level mental health during the pandemic. So I hope that soon we'll be back to environments where we can have that brainstorming in person, but at least this has led to, I think, some important work during this time. So my goal is to sort of summarize some of the work we've been doing and sort of the results that are seen in general, again, sort of with a mental health focus. Great, so again, just sort of outline, we'll talk a little bit about the need to monitor mental health and that our efforts to do so. There's lots of groups doing this, and I'll highlight some. And this is by no means comprehensive. So there's a lot of work happening, which is wonderful. And then I'll talk about some of the findings and implications. So this particular graph is from the US SAMHSA, Substance Abuse and Mental Health Services Administration, and just gives a little bit of the sort of theory and background of thinking about mental health during public health crises. And sort of this idea, again, this is not specific to COVID, more general, of kind of some impact that happens. I think you can see my mouse, maybe. Sort of pre-disaster, some impact, and then a big sort of immediate emotional high as people kind of deal with the immediate crisis, a quick sort of decline and these sort of events that might trigger emotional lows, and then eventually sort of a slow, steady reconstruction back to a kind of normal state in terms of mental health. And again, sort of just, I'm not giving a huge literature on the previous research on disaster mental health, but certainly there is a large body of work in this area and talking about things such as those mental disorders that are more common after disasters, such as PTSD, not surprisingly, but then also documentation of major depression, anxiety, and substance use increasing after these sorts of disasters. And certainly there's sort of certain symptoms in particular, like avoidance and numbing, that are hallmarks of this. One interesting piece, and I'll come back to substance use later in the talk, is that previous evidence shows that substance use is common and increases during and sort of as people are recovering from some disaster, but not substance use disorders. So sort of increasing levels, but not necessarily going all the way towards people developing substance use disorders. There's also a large body of research on resilience, which sort of relates to some of this, and just this idea that some different people are going to be affected differently by these disasters. For many many people are going to experience some emotional response, but then one of the key things to examine and identify are those people that are not going to have a normal recovery, those people who continue to have substantial challenges, substantial problems with everyday functioning, that really, again, don't sort of resolve on their own and require more help. And again, we'll come back to this in the context of COVID in a bit. So again, like there's previous research on this. Probably some of you on this call are experts in this in a way that I am not. But what we've really been tackling in the past 6 months is, again, sort of what about during the COVID-19 pandemic? And so I'm sure this is the case in the UK as well, and Europe and all over. There's sort of substantial, I would say, kind of general concerns about potential increases in mental distress. The figure on the left is from a very nice article, actually, that the Washington Post did. There's been various news stories. And there's some sort of provocative data. So 20,000 people texted the SAMHSA hotline in April compared to 1,800 the previous April. Mental health screenings, sort of use of just general mental health screenings on the Mental Health America website increased 60 to 70%. And in those screenings, the number screening positive has increased by 20,000 compared with January. So these are kind of not anecdotes, but sort of data anecdotes, I might call it, indicating that there might be something going on. And there's certainly been discussion kind of in the news. And again, this just sort of pulls out some headlines from different news sources, pandemic fatigue. And I think actually this was from July, but this is an even more timely topic right now for many parts of the world. These concerns, especially in the US, about racism and how the racial aspects are kind of interacting with COVID right now. Lots of attention to young people and sort of how young people might be affected by social isolation. A lot of, on the bottom right, sort of these family concerns and sort of worries about people who are home with small children and sort of suddenly, and then seniors too, a lot of concern. And in fact, when we started all this work, I'll come back to this, we were particularly worried about seniors. There's sort of a feeling of, well, the older adults, they might not be as ready to use Zoom or connect through virtual means, and they might become very isolated. So again, there was lots of sort of discussion and general concerns. So what our group, though, is trying to do is put some data and evidence behind these sorts of headlines and kind of really understand what is really happening. And I want to highlight this public health and sort of population approach to this problem. So my department, the Department of Mental Health, is, at least in the United States, the only department of mental health in a school of public health. And so it's different from, say, a psychology department in that we really are focused on the sort of public health aspects of mental health and sort of thinking about mental health from a population perspective. So we're not really thinking about individual treatments for people or how to do that, although certainly there's recommendations that would come out from this public health approach. And again, I'll come back to that later. But what we're really interested in our work is this idea of, well, how do we track mental health in the population and study that? And this is challenging for multiple reasons. Any of you who study or know anything about mental health, one of the problems is measurement. I mean, there's substantial problems with measuring COVID right now, but there's also substantial challenges in measuring mental health. We don't have a blood test for depression. It's, to do a formal diagnostic interview takes a lot of time. And so there's this sort of tension of wanting to get population level data, but then also needing to do so in quite efficient ways. And then again, it's also hard to get population level data. So like the Mental Health America website I mentioned earlier, those are people who are going online and electing to fill out a survey. In the work we've been doing, we've really been putting a high priority on collecting data on representative populations and sort of really trying to get at what is the population levels of distress and try to avoid sort of selecting only those people who are already experiencing problems or who seek out help and that kind of thing. Other people are doing wonderful work in those areas. Again, I'm sort of just trying to highlight where we were trying to sort of fill a data and evidence need. Okay, so as I alluded, in March, a group of us started what we're calling the Johns Hopkins COVID and Mental Health Measurement Group. And again, as I've alluded to, our goal was to get sort of a set of what I would call sort of core foundational mental health measures on ongoing US and international surveys. Again, these are not diagnostic measures. These are not clinical diagnoses of depression. These are questions very short, meant to get at things like how many days in the past week did you experience symptoms of depression? How many days in the past week did you feel anxious? Have you felt lonely? Just sort of very high level, again, what we're calling mental distress. One irony looking back, which is sort of sad that well, at the time, this was again sort of mid-March, and we thought, oh, we really need like short-term measures. So some of the measures that are sort of validated measures in the literature ask about the past month. And we worried that asking about the past month would not be fine-tuned enough for the pandemic, because we thought, oh, people are suddenly experiencing challenges. We need to get a more tighter window. And so depending on the survey, we've sort of gone more to like 7 days or maybe 2 weeks. There's some nuances on that. Sadly, though, looking back, this pandemic has continued much longer than any of us, I think, were thinking it would in March. And so, probably month scale would have been fine, given how things have panned out. But again, at the time, we were sort of focused on these sort of short-term measurements. So here, I'm going to show some results from some of the specific studies, but just to briefly mention, again, the other thing that we've really tried to focus on efforts on are longitudinal studies. So in particular, building on some surveys that had already been in the field and being conducted, and that where we could make sure to add some of these core mental health measures. Some of them, I should say, I didn't say this explicitly, but we also, when possible, when we sort of got more survey space, added like substance use measures and some other variables, not just the anxiety and depression. So the first two of these are the ones I'm going to focus the most on today. But one was the Pew Research Center has an American Trends panel, and then the Understanding America survey. And I'll describe these in a little bit more detail as we go along. Again, both of those were long-standing surveys going on in the US, both nationally representative. And then the third was the COVID impact survey, which got started as a result of COVID, hence the name. And again, we helped get some of these mental health measures on. I think for this international audience, so I want to make sure to highlight some international partnerships. And in particular, we have been collaborating with some teams working with Facebook to do very large scale surveys using the Facebook platform, where literally, I think we have 15 million responses in the International Symptom Survey. Daily, Facebook users are kind of given a ping to respond to a survey as part of their own Facebook feed, not as an ad on the side. And we are getting sort of very small numbers of items of questions, but very large scale data. And I'll come back to that later. And that's, again, sort of international. And then a Life in Australia survey, also a survey in Germany. The webpage listed at the bottom gives sort of much more detail on all of these. I should really note that one of the ways this was all possible is through a colleague of mine, a colleague and friend, Frauke Kreuter, who is at the University of Maryland and in Mannheim and Munich in Germany. And she is very well connected in the survey world. And so basically in March, we kind of put together a one-pager of like, hey, here are some mental health measures. And she distributed that to the Public Opinion Research Association and sort of looked for potential partners who were interested in collaborating with us in getting some of these measures. And so that's really how we were able to get these measures on a large variety of data sets, again, sort of all around the world. So huge thanks to her and the connections that brought us. And I think it was in some ways a nice example of a place where many of these firms or the people conducting these surveys were very happy to include mental health measures. They sort of knew that it might be important, but they did not have the expertise to know sort of what questions to ask. And so we were able to bring that and sort of develop this nice connection and collaboration to then do this data collection. So the sorts of research questions that we're now using this data to answer, and I'll again sort of highlight some of these results, are who is experiencing particularly high levels of distress? How does media consumption relate to distress? What have trajectories of distress looked like since March? I'll highlight some results about people without pre-existing psychiatric conditions. And then some of the questions we're asking are more community level. So what community factors are related to particularly high levels of distress, and how do policies relate to this? So clearly I don't have time in this 45-minute talk to go through all of these, but again, just wanted to give you sort of a sense of the sorts of questions that I think are important. So let's turn to some of what we have learned so far. The one I'm going to start with is actually not a survey that was part of that particular group, but was conducted by some colleagues at Hopkins, Beth McGinty and Colleen Berry and Henry Hahn, and then a student, Rachel Presskreischer. But it follows the exact same model that I was talking about, with the one exception that they started this panel. So they have this really interesting survey that they're calling the Johns Hopkins Civic Life and Public Health Survey. And it's getting information not just about mental health measures, but also civic life and sort of engagement in politics and sort of how that interacts with the COVID pandemic. It's using, I don't know how familiar all of you are. Actually, I'll take a minute to describe this AmeriSpeaks panel because it's the same structure as the Pew one and the Understanding America survey that we collaborated with. Essentially, what these panels all are is that different companies, AmeriSpeaks is run by NORC, they have selected a nationally representative sample, their panel as they call it, and they've done so in a very strategic, thoughtful way where they have made efforts for, it's all done online. So the panel members, become a member of the panel, and all of the surveys are done online. But the companies, again, either Pew or NORC or the University of Southern California, have made a real effort to give devices to people so that they can participate in the panel. So it sort of avoids some of the problems that some internet surveys have, where they have gone to great lengths and great expense to ensure that they can reach all of the different segments of the population, and not just those who have easy internet access. They sort of facilitate that internet access for the panel members. And so what happens with these panels is individual surveys then sort of reach out to the panel members, is essentially the way it works. And Pew and the USC one that I'll talk more about have these ongoing longitudinal surveys of their panels. And again, that's sort of what we were able to kind of jump onto with some of our mental health measures. So this one in particular, again, sort of run by a team at Hopkins, did one survey in April and asked what's known as the Kessler-6 psychological distress scale. So this is a internationally validated scale that has 6 questions, and there's a sort of somewhat validated threshold of 13 on these questions, again, sort of getting at anxiety, depression, these sorts of psychological measures. And a score of 13 is meant to identify serious psychological distress. And what was nice about this K6 is that they were able to compare this April 2020 response with basically the same set of people, not the exact same people, but sort of same type of people, nationally representative, from 2018. And so this is published in JAMA, and this is, again, just sort of data documenting what many people had been concerned with. So if we look at the very top bars, they showed that in 2018, about 4% of the population was showing serious psychological distress. And 2 years later, in April of 2020, that rate had gone up to 13%. So about a tripling of the sort of psychological distress measure. And what was particularly striking too is that, so we had this theory that older adults would be quite affected, but in fact, what this study and others have been showing is that the increases are particularly pronounced among young people. Sort of this cut off is particularly 18 to 29, but sort of in general, it's sort of under 25 or so is showing particularly high levels. And we can talk maybe more later about why. I think one of the theories is these are people who really are experiencing substantial disruptions to their lives at a time when they were just starting to sort of emerge into adulthood, and that this is sort of throwing quite a wrench into how they were imagining kind of their early 20s. The other group in the older adults, there's sort of some feeling that maybe the older adults have better resilience and sort of coping skills And so are able to weather this actually more effectively in some ways than we were expecting. The other group that you can see here that's substantially affected are those with low income. So incomes here less than $35,000. And again, this is very consistent with other studies that we and others have found showing the sort of interaction between COVID and the financial stress, and the people who have lost their jobs or who are experiencing financial challenges as a result of the pandemic are particularly hit in terms of their mental health as well. So again, this is sort of one piece of data, but quite consistent messages with some others. And perhaps not surprising when you think about it, but it's useful to see the data. So another group, so now turning to some other work, we were particularly in some sense interested and worried about people who maybe don't have a prior mental health diagnosis. So most people in the United States don't have a pre-existing mental health condition. So this is a group of people who are not necessarily familiar with the mental health care system. They are not connected already to mental health service providers. There might be a lot of self-stigma and even sort of confusion when they experience symptoms. It's just not something that they had experienced before. But also, there are likely preventive measures that they can take to prevent exacerbation of symptoms. So we, in this case, used that relationship with the Pew Research Center survey to look specifically at, and again, sort of using previous rounds of the survey, which had asked about psychiatric diagnoses. We looked in particular at the about 10,000 people who had not had a prior psychiatric diagnosis. So again, this is a US nationally representative sample of individuals with no prior psychiatric diagnosis. In this case, any of you who are mental health researchers, we had items from the depression scale, the CESD, and then a general anxiety scale, the GAD-7. And we basically were looking in this sample at associations between different demographics and different COVID variables and mental distress. And this paper was published by a postdoc with us who is a former PhD student, Calliope Holling. She, by the way, is on the job market, so keep an eye out. And this was published in Preventive Medicine in August. Oops. So this plot shows among this, again, this group of people that had not previously had psychiatric diagnoses. We see, so the white bars are essentially no symptoms in the past week. The light blue is 1 to 2 days, the sort of teal is 3 to 4 days, and then the dark blue are people who had 5 to 7 days of psychological distress of these different types in the past week. So 15% of this group had basically all week feelings of nervousness, 6% feelings of depression, 6% feelings of loneliness, 11% trouble sleeping almost every day, and then very low hyperarousal. But again, so this is a substantial number of people, a percentage of people who again are not connected to the mental health service system, but might be experiencing levels of distress that sort of are really sort of interfering with their day-to-day functioning. We also looked at risk factors for these higher levels of distress. And I'll highlight a few. There's sort of lots of results in here, but I'll just highlight a few. One is, again, this age relationship where we saw exactly the same as what I mentioned with the earlier study, with sort of lower levels of distress as age increased. So the highest levels were among the young, the sort of excluded group actually, which is less than age 30. Again, sort of this second circle is showing that sort of rates were lower among the higher income. So in this case, the reference group is income less than 40,000 a year, and they had the higher levels of distress. And then over on the right-hand side are sort of COVID-related variables. And again, sort of not surprising, we see higher likelihood of distress among people who felt that COVID was a personal health threat, either a minor or major personal health threat to them. So again, we can sort of just start to unpack who are the people who might need help getting connected to services or prevention strategies, whether it's a new app or just whatever connection to services they might need. So again, this is a little bit of sort of random topics, but hopefully I'm giving you sort of a sense for what the landscape is looking like. I want to turn to longitudinal trajectories. So what the studies I've talked about so far have been underlying longitudinal data, but us just looking at sort of cross-sectional rates of distress. So what we can turn to now is this collaboration that we had with the Understanding America study, which is run out of the University of Southern California. And what was wonderful about this one is that they, again, are one of these panels where they are going back to their panel members periodically to complete surveys. And again, it's US nationally representative. And what's wonderful about this one is they were able to get some supplemental funding, including we got a supplement from the National Science Foundation for the mental health measures in particular, where they were able to increase the frequency of their surveys of their respondents. And so essentially participants completed surveys about every 2 weeks, and sort of staggered in such a way that we have about 400 to 500 responses every day. And so what we're able to look at in the next couple slides are the probability of reporting mental distress and then alcohol use between basically mid-March and mid-May. And actually I'm realizing this, the site at the bottom is wrong. It's from the previous slide. So here's the correct one. This paper is under review right now. So this shows, again, sort of from March on the left-hand side to May on the right-hand side, trajectories of mental health distress. So the y-axis is predicted probability of mental distress. And again, sort of think of that as a mix of sort of more than 50, this is a bit of a simplification, but about 50% of the time experiencing symptoms of depression and anxiety. And so we can see, again, sort of trajectories over time. We can see, for example, that females start out higher. Both, everyone sort of goes up over time, sort of from March to April 1st, but then a decline back down. So actually by May, overall, people are, men especially are back down to sort of the levels they had been in March. Women actually remain a little bit higher. But there is some difference across different demographic groups. So you can see, again, back to these 18 to 29-year-olds, the red bar at this in panel B, they start out much higher and they stay substantially higher and sort of more of a flat curve over time as compared to the older age groups, which again, sort of in a sharp increase, but then sort of a slow decline back down somewhat. Interesting patterns by race, ethnicity, with sort of lowest rates among Blacks, and the others are kind of all bundled up together here. Interestingly, we had all these theories about household structure and how, I don't know, I have 2 elementary school age kids. The spring felt very rough in terms of everyone home unexpectedly. And we had all these theories about, well, but maybe single people will be lonely and maybe people with kids will be stressed because they're all home. And, interestingly, we don't actually see much patterns there, at least here. Maybe slightly lower rates of distress among people who live just with a partner. That's the blue line at the bottom. And other than that, it's just kind of a muddled, just sort of muddled. So that was interesting. But again, as we saw earlier, financial stress really matters. And you can see that people living below, in the US, we have what's called the federal poverty line. People living below the poverty line, again, started out with much higher levels of distress and really stayed high throughout the time period. Again, sort of this is where your intuition and data don't always align. We sort of had this whole theory about that, basically sort of underlying this is interest in sort of tracking how mental health tracks with the pandemic itself. And sort of through various analyses, we've been trying to understand whether distress is higher in areas where the pandemic is hitting more fully. So we had this whole theory that, like in this case, in March, basically that was when in the US, it was mostly sort of Seattle and New York that were getting hit particularly hard by COVID. And we did some analyses of and there was maybe some signal that rates of distress were higher when states were hit earlier, but you can see here very little And you can sort of see that with the West and I guess West and Northeast, like we do see that a little bit, but that over time, as this quickly became a national pandemic, there's really not much relationship between area of the country and distress. This graph shows the same idea, exactly the same groups and the same kind of picture, but for alcohol use. And I don't know, this has been sort of all over the news in the United States, and not this exact finding, but just this general idea that, and we can see in our data that use did, this is, the question was like, how many days in the past week did you drink alcohol? My substance use expert colleagues are a little bit sad that the survey doesn't get into binge drinking. So it's really just a measure of the number of days. And my colleague Johannes Thruel is like, I wish we had like, binge drinking measures, but in this data we don't. But this is showing that, again, sort of from March to May, there was an increase in the number of drinking days, and then sort of a flattening. Again, the males sort of have flattened. For females, it went up and has come down a little bit, maybe still a little higher. Again, but not sort of huge dramatic differences in terms of how things look. Although by race, ethnicity, there are some different patterns here, with sort of the whites going up more quickly and then staying sort of flat. No differences across census region, as you can see down here. So I want, again, especially for this crowd, want to talk a little bit about what things look like internationally, because most of the work we've done so far, published so far, has been using these US samples. But I'll highlight this Facebook data, and there's a link at the bottom of this slide, which is really, I think, a very valuable resource. So again, essentially, this is a survey of Facebook users, millions of records per week from April all the way through current date, and it's continuing. And it allows the sample and the study design, the sample design allows inferences down to the county level in the US, and then sort of sub-country levels across the world. It is not longitudinal on individuals, so I think it's most useful for sort of looking at like longitudinal trends and at community levels, or relationships between, for example, they ask about COVID symptom measures, also behaviors and some basic demographics. So just to whet your appetite a little bit, here are just some graphs. We have not published any of this yet. It's sort of our data investigating as we sort of think about things. But on the left are weekly trends in depression symptoms for OECD countries, and on the right are anxiety symptoms. And I think what's really interesting, I don't know how well you can see, it's pretty tiny font, but for most countries, things are fairly flat. So, and sorry, the time, oops. Sorry, previous. The time scale is from April to October. So, this graph is a pretty long time period. And again, you can see for most countries, things are pretty flat. There's a lot of variability across countries in just sort of average levels. But most places things are fairly flat. There's some exceptions to that. So Chile has a decline over time in anxiety. There's some jumpiness, partly because of, I think, small sample sizes in places like New Zealand. Turkey seems particularly high. Anyway, we're sort of still trying to figure out how to make sense of all of this and what questions to answer. But again, I partly just wanted to highlight the potential for this data. And I should say this data, the website I listed on the previous slide, and I have at the end, I believe, as well, or you can find it, is publicly, I mean, you have to go through a small data process just to get permission to use the data and sign the appropriate paperwork and data protections. But it is open to researchers. And so I think it's a wonderful resource for people who want to study these topics. So let me just take a few minutes to talk about where do we go from here. I've given you sort of a snapshot of a variety of different studies. I think this is a bit of a random topics, but I think we can use the sort of epidemiologic research that's been done to start understanding how we can think about prevention and treatment strategies. So I think this first bullet is sort of this, again, sort of over and over is coming out the the role of financial stress and sort of financial stressors in mental health. And so thinking carefully about government relief efforts to address some of these social determinants. One thing that I'll get back to in a minute is, at least in the US, I don't know about elsewhere, there's been dramatic changes in the laws and regulations to allow for telemental health services. And this is actually, I think, really important. Well, I'll come back to that when I have it on the next slide. Again, sort of, there's some concerns about providers being able to weather this situation, and so potentially some need for supporting their financial survival. I think increased awareness and messaging around things like helplines and hotlines, such as in the US, the Suicide Prevention Lifeline. Some locations are putting together networks of volunteers to call people who are isolated and just check on them. There's sort of workplace supports that are being provided. And then I think there has been some attempts in the media and through, again, sort of workplaces around messaging around wellness and self-care. And I think one of the challenges here is sort of helping people, like, this is a stressful time. And so part of the challenge is helping people figure out when does it move beyond just sort of general distress that can be managed and handled and is sort of a normal part of dealing with what we're all dealing with right now, versus something that rises to maybe reaching out for more formal support and help. Sorry, let me talk for a second about, so I want to come back to this telemedicine. Again, I don't know how things are in the UK or other countries, but one of the challenges with mental health service provision in the United States in general is a general lack of access. And one of the reasons for lack of access is particularly a limited supply of psychiatrists and psychologists in rural areas. So what's been really interesting about the pandemic is that health insurers and government entities that regulate mental health services have really relaxed restrictions around telepsychiatry, telepsychology, telemental health. And so this is, I think, has the potential to change mental health service provision sort of over the long time frame, and might actually help increase access for people who currently, have trouble accessing it. Actually, just yesterday we had a seminar on this, and one of the psychologists who was participating in the panel commented that, even in his case, so these are people who didn't have access problems, but they love their Zoom psychology visits, and they say, oh, it's just so much more convenient, and he has many fewer canceled appointments. People don't have transportation challenges. It's just easy. So I think people who are already seeing a provider, who have an established relationship with a provider, this is opening up new possibilities. And again, it might also be really quite impactful for areas of the country that have not had good access in the past. So I think, but that's all of that said, we very much need to study kind of how it's being used. Is it actually effective? And sort of really dig into those questions. I think we also sort of at more of a public health population approach, we need to think a lot about these communication campaigns and strategies that are being used to try to reduce stigma, increase care seeking, give people the tools to help them manage their symptoms. Huge questions around the effects of prolonged social distancing, again, as this continues and countries go back into lockdown. Again, this is continuing, I think, longer than many of us thought, and so really continuing to monitor that. And then, of course, lots of interest in the role of resilience and pro-resilience factors, both for individuals, communities, and societies sort of overall. So there's this really nice paper by Smith, Sullivan, and Dress that came out in Psychiatric Services quite recently. And they, again, just sort of articulate this population health approach. So identifying high need individuals, and I didn't have time to get into this today much, but I think there's really, I was sort of focused more on general population, but there's some really important questions about specific subpopulations. So, people who are homeless, criminal justice involved, those with serious mental illness. I am involved with a team at Hopkins where we are doing some data collection around people with substance use problems and looking especially at people with opioid substance use problems who might be receiving medication-assisted treatment, and sort of looking at the disruption that they might be encountering as their sort of providers have to close, and how do they distribute buprenorphine or methadone. And so we are doing some primary data collection to really understand the experiences of people and sort of how to make sure that they can stay connected to the treatments that they were receiving and need to continue to receive. Smith, Sullivan, and Dress also sort of articulate a goal of partnerships between private, public, and state-operated systems, smart use of telepsychiatry, as I was mentioning earlier, and then really interesting questions about sort of, as you know, again, in the US, there's been long-standing debates about psychiatric hospitals and helping patients transition to the community. And I think COVID has really enhanced some of those conversations and sort of made it even more urgent. And again, sort of a prevention approach across the board. So to summarize, psychological distress has certainly increased among adults during the COVID-19 pandemic. Again, we see this sort of overall and with among those without pre-existing mental health conditions. And particular risk groups include those experiencing financial distress and younger individuals. We really have to, again, sort of monitor these concerns about the long-lasting and sustained mental distress as this pandemic continues. But there's lots of data. So again, one of my goals with this talk was to hopefully show you some of the data that is available and lots of questions. So here I've just highlighted some of the I think, open questions. So again, implications for service systems, lots of concerns about disruptions to existing service systems. The WHO just published something on that. We need to think about how to connect individuals with services that they need. And then again, I didn't really focus on this, but you know, we don't have any direct data on children in the surveys I've talked about today. There are some other groups that are trying to collect data on children. And I think those sort of special populations will be really important to monitor as well. So I want to take a minute to acknowledge, again, sort of our COVID and mental health measurement working group. You know, this is one of our Zoom calls where that's really how the work has been getting done, of course, for all of us. And then I want to acknowledge some funding. So again, the National Science Foundation helped support some of the work with the Understanding America survey. The Bloomberg American Health Initiative has supported some of my time, and also this Alliance for a Healthier World project at Hopkins. And again, we couldn't have done this without partnerships. So this wonderful connection with Frauke Kreuter at Maryland/Munich/Mannheim, Facebook, the Pew Research Center, and the USC Understanding America study. And then I know this is tiny font. I'm happy to share these slides. Actually, I'll try to put it on my webpage. But this, I've tried to give just a lot of resources, and I'm happy to, again, share these. But the web pages listed here give more details on the data sets that we have access to. Some nice sort of easy overviews of the work. Hopkins did a sort of snazzy video profiling it. And then here are some of the publications. So I hope that was a helpful whirlwind, but I really look forward to questions and conversation.